Okay, shoulder assessment. Just turn around for me. That's it, 180 degrees, good. Okay, so first of all, obviously get someone into a bra or vest top where you can see the scapula. First we're looking for is observation, so we're looking for, as with every other joint, bony deformities, any sign of swelling, any sign of heat, any sign of basically obvious injury. So we're looking at bruising as well. We're looking at general posture, so we're looking at the line of the shoulders, we're looking at the gaps between the arms to see if she's leaning one side more than the other. Just lean to this way if you like. So we can see now there's a little bit more of a gap on this side compared to there. Back to middle. We're also looking at the centre of the spine. We're looking at the scapular positioning as well. So we find the medial borders of the scapula, and there, just to draw it on. Okay, and they should be around about 4 inches apart. Looking to see obviously that they are vertical. Find the inferior angles on either side, see if that's level. Relatively level. Look at the top of the shoulders, spinal scapula. Okay, turn around. From the front, we're looking at the front of the shoulders as well. Looking along the line of the clavicles to see if there's any obvious deformity. Looking at the gaps again. Come to the side, we're looking at any excessive protraction or retraction. Looking at head positioning as well to see if there's any chin poke or chin tuck too far back. Looking at both sides if there's any difference. Okay, just take a step forwards. Okay, when I say I want you to lift, in fact, let's not miss out palpation first of all. So for heat, check for heat. Okay, from there, I want to palpate from the clavicle, along the clavicle for any clavicle fractures, along to the AC joint. If you separate her AC joint, that will be extremely painful. From there, across the acromion angle, down the spinal scapula and the medial border of scapula. Turn around. From the medial border down to the inferior angle and the medial border of scapula, I can come across and just palpate a few of the rotator cuff muscles. So I know teres major and minor, infraspinatus, come around to kind of supraspinatus area. So just palpate to see if she gets any pain. From around the front. Around the front, we palpate the coracoid process. From there, I can palpate long and short head of biceps. Long head of biceps. No pain on that?
No.
Okay, which is usually in your shoulder.
This one.
Okay. Come around the side just for deltoid insertion, coming down, no pain on there.
No.
Okay. We want to make sure we look also for any bruising or swelling around here or here. If she has ruptured her biceps lower down or higher up, there will be some bruising or swelling either here or here. Okay, so now what we do is arms forwards and up to the top when I say, and then back down. Okay, go. Okay, and back down. So I look up from the front. One, I want to see facial expressions, is there any pain? Secondly, look from the back. So go forwards and up for me again. Okay, and again I'm looking at, back down, I'm looking at scapular rotation, I'm looking at scapular humeral rhythm. You can see from Jo that her right arm doesn't flex fully into elevation. Okay, now I want you to go into abduction, so pull the arms out to the sides all the way up to the top. And again, she's not liking that at the top, back down. So again, a couple of times from the back and from the front. Okay, back down. Okay, I'll do you good arm only.
Okay.
Okay, just this arm, forwards and all the way up to the top for me. Okay, when we get to the top, a little bit of passive overpressure. Back down. Just stand facing that way for me so I can show. Hand at the back of the scapula, go again. So support, gentle overpressure. Back down. Abduction, so turn facing the camera. And now, you'd obviously do that the same the other side. Abduct up to the top. And again, gentle overpressure the opposite side. Support and overpressure. Back down. Okay. From there, looking at passive medial and lateral rotation. Same as we did for all the other movements of the shoulder, we want to basically fix her elbow by her side with my body, fix her opposite shoulder, and all I'm going to do is externally rotate and step away. Looking for an end feel, elastic end feel. If the patient is really tall, you can get them sitting down or stand next to them, fix the side with your hand, and externally rotate. That's a good one, isn't it?
Yes.
Okay, good. Okay. Face that way for me. Medial rotation, hand behind your back. Any pain there?
No.
If it's her left arm, use my left arm, hand on her back, elbow on her upper arm. Medial rotate, again looking for an elastic end feel. If I don't fix that arm in position, we're just doing extension. Okay? Face the camera. Okay, horizontal adduction, otherwise known as a scarf test, specific test for AC joint separation. Arm flex to, or shoulder flex to 90 degrees. The hand goes at the back of the scapula on the medial border. I've got the weight of her arm. Gently push across until I feel the medial border just start to come away, which is there, and a gentle overpressure. What you're doing there is basically pushing the humeral head across. You're pushing the acromion across onto the clavicle. So if those two joints, the acromion and clavicle, are going to start pushing up against each other. If there is any separation there, that's going to cause pain. Resisted tests. Okay, you've got ab and adduction. Arms straight. All I want you to do is from there push out against me. We're going to have a hand above the elbow and below the elbow. Push out against me. Any pain?
No.
Relax. I go around the other side and do the same thing. Come back to this side. Adduction. Above and below, just on the inside. Keep your arms straight and pull to your side for me. Okay, go. Good. And relax. Any pain?
No.
Okay. Joe's not the biggest, obviously, but if I've got a 20-stone rugby player, make sure you've got your arms and your legs in that position so you can use your legs to resist, not just your arms. Medial lateral rotation. Again, same position as you did for passive medial rotation. All I want to do now is hold your arm there, and I want you to pull your arm across your body like that. Yeah. Okay, go. Go on as hard as you can. Good, and relax. Any pain?
No.
Lateral rotation, just hand on the outside and push out against me like that. Go. Any pain?
No.
Make sure you keep your elbow by your side. Go again. That's it. Any pain?
No.
Good. If they are really tall or you struggle with that, again, get them sitting, or you can do it. Arms like that for me. Keep your elbows tucked by your side. Face this way actually so the camera can see. Put your hands on the outside for lateral rotation. I want you to push out against me. Go. Good. And relax. Don't worry about pushing with this side, okay? For medial rotation, hands on the inside, push in. Go out as hard as you can. Good. And relax. Okay. Any pain?
No.
Okay, face that way. Shoulder flexion, otherwise known as Speed's test. Test the long head of biceps. So we're looking at tendonitis of biceps. Obviously, resisted medial and lateral rotation will test the medial and lateral rotators. Speed's test, flex to about 50 degrees. Thumb facing the ceiling. Thumb above and below the elbow. Keep your arm straight and push up against me. Push. Good. Any pain?
No.
Good. And then what I like to do is palm facing forwards. Extend about 15 degrees. Keep your arm straight and pull forwards for me. So as if you're trying to bowl underarm.
Okay.
Okay, go. Any pain there?
No.
Okay. Because I've stretched the long head of biceps, keeping the arm straight and resisting, that's putting a lot of stress through the bicep or biceps tendon. Okay. Elbow flexion extension. We want to test the biceps and the triceps because they go over two joints. Obviously over the glenohumeral and the elbow. Although Joe's not the biggest, I'm going to do it as if I'm testing a 20-stone rugby player. So elbow bent to 90 degrees. Grab the wrist. When I say grab the wrist, we're not squeezing tight, it's just a support. Elbow pointing in the air. I support my other wrist and use my body weight. Okay, so when I say push up, there you go. Go as hard as you can. Good, right? There's no way she can overpower me if my elbow is in that position. For triceps, a resisted elbow extension. Palm facing down. Again, grab the wrist underside. I come underneath it. Elbow over to my side. Hold against me. If my arm, my forearm, is horizontal, push down, she'll overpower me. My arm is now vertical, push down. Okay, go on, lean into it. Go on. Okay, there's no way she can overpower me. So keeping your arm into your side and push up through your legs. Special tests, we've got empty can. So for this, face me. What I want you to do is arms forwards 45 degrees, abduct 45 degrees. Okay, from there, turn your baby fingers up. Just this side, okay? And push up against me. Okay, relax. I get patients to push up both sides. Because Joe's got an injury to this shoulder, we're not doing that side. Okay? Positive pain on that is, as they push up, they get pain elicited along the top side of the shoulder, most commonly in impingement syndrome, so supraspinatus, that sort of thing. O'Brien's test, come around this way. O'Brien's test is going to test for slap lesions. So again, arm 45 degrees flexed, this time adduct 45 degrees, baby finger up, push up. Good, and relax. Any pain?
No.
Turn around, thumb facing upwards, push up. And relax. Any pain?
No.
Positive test on that is when the palm is pronated and pushing up, you get pain. Then when you actually supinate the arm, push up, it releases. And the main reason for that is, as we pronate, the humeral head is rolled over into the joint, so it's compressing the labrum. Pushing up makes sense, then it's going to start rubbing against the labrum and cause pain. When we then supinate, it rolls around and releases that joint. As you push up, there's no compression on the labrum. Okay, Hawkins-Kennedy. Arm in that position, so 90 degrees flex, 90 degree flexion at the elbow. Facing forwards, supporting my arm, so our arm is nice and relaxed. And I just medial rotate to end of range, and lateral rotate to end of range. Any pain on those?
No.
You're looking for pinching or pain along the front or along the top line of the side of the shoulder. That will again indicate long-headed biceps or supraspinatus impingement or tendonitis. Again, makes sense because as you're rolling over, you're going to be decreasing that subacromial space and pinching on those tendons or those muscles. Okay, apprehension, relocation, and sulcus sign. These two are going to test for anterior instability and inferior instability. Can you pop your shoes off? Sulcus sign first. So sit on the bed, face that way. Sulcus sign, nice and simple. Arm resting on their thigh. We find the acromion angle and the acromion process. Drop off that. And now in the joint space between the humeral head and the acromion angle. Use the medial and lateral epicondyles as a grip. And I'm just going to pull down. I'm looking for the humeral head to drop down. If the humeral head drops down, you'll get what we call a sulcus sign there, which is where it will create a shadow and a dip. Stands to reason if that humeral head goes down, the inferior capsule at the bottom here, which acts as like a bag, obviously the humeral head pushes through that. So you're looking at either a rupture or that to be unstable. You're also looking at the inferior glenohumeral ligaments to be unstable on that. Last one, line with your head at this end. So we go on the shoulder.
Yeah.
Okay, apprehension, relocation. Just come to this side of the touch. That's it, that's fine. Just don't forget your pain. So I want to abduct to 90 degrees, have the elbow flexed at 90 degrees, hand point towards the ceiling, my inside hand just supporting the glenohumeral joint on the humeral head. I'm going to externally rotate until I see or feel any apprehension. That can be in the form of facial expression. She can start resisting me, she'll start getting pain, or she'll start actually telling me she's in pain. So I'm going to externally rotate. Anything there?
No.
Okay, I can start to feel her start to tense up against me. There?
Yeah, it's starting to get a little bit.
Okay, so just before 90 degrees. So what I want to do now is push down with the humeral head to relocate. Now other than pressure where my hand is pressing on the humeral head, anything there, or does that feel better?
No, that's better.
Okay, that's a positive sign on apprehension relocation. And again, it makes sense. When we're in this position, as we externally rotate, the humeral head wants to translate forwards. So if she's ruptured her anterior glenohumeral ligaments, subscapularis, they're not working and holding that humeral head back. So the relocation part, bring the arm back to neutral, relocate the humeral head back, externally rotate, feels a lot better and a lot more comfortable. Okay, and that's a positive apprehension relocation test. Again, common in football, not football, rugby, throwing sports because of dislocation. And that's a shoulder assessment.